First of all, I want to say thank you, Stefan and Dan, for inviting both of us to present the efforts that our agency is undergoing to promote health, wellness through technology and information. We'll talk a little bit today about the impact at the community level of healthcare and what the ONC is doing to move us forward. I want to give you just a little bit of background about our agency. We were created in 2004 by executive order and legislatively mandated by the HITECH Act of 2009. We're the principal federal entity charged with the coordination and federal nationwide efforts to implement and use the most advanced health information technology and advance electronic exchange and interoperability of electronic health information and the policies that support data movement. I think it's really important that we set the framework and mention that the Recovery Act set out to lay the groundwork and the infrastructure throughout the nation to make sure that we were promoting the most advanced use of technology to support healthcare. Through the HITECH Act, there were 4 programs that were designated to be administered through the ONC. I wanted to talk a little bit today about the Regional Extension Center program. And the goal of the Regional Extension Center program was to support the adoption and use of health IT of 100,000 primary care providers throughout the country of the existing 302,000 at the time. So the goal was to help 100,000 of the nation's 302,000 primary care docs lay that groundwork and infrastructure with health IT. Regional extension centers were located throughout the nation, had defined service areas and specific number of providers that they were designated to support and providing unbiased practical support through process improvement, and they served as a two-way pipeline to both federal and local resources. Just wanted to show you some of the things that the regional extension centers did once they went into those practices throughout the nation. Just to highlight a few of the technical assistance that they provided on this list is practice workflow design, health IT optimization, vendor selection assistance, privacy and security assessments, and meaningful use optimizations. I'm very proud to say that this is the current data on how successful the extent and the reach of the regional extension centers were able to provide. So there are 3 milestones with the program. Milestone 1 that you see is that a provider in the community signed up with a regional extension center. And as you see, we have successfully signed up and are working with 157,000 providers throughout the nation. Our second milestone was getting those providers live on an EHR. And as you see through the second milestone there, we were successful in assisting 144,000 providers throughout the nation go live on an EHR. The third milestone is achievement and demonstration of meaningful use. And to date, we have successfully assisted over 112,000 providers achieve meaningful use. And as I mentioned, working with over 150,000 providers in the United States to date. Just wanted to highlight a few of the benefits of the relationship with regional extension centers. That the GAO report found that Medicare providers working with RECs were over 1.9 times more likely to achieve meaningful use and receive an EHR incentive payment. This slide just demonstrates the tremendous advance in health IT adoption over a very small period of time, both within the physician primary care setting and ambulatory setting, as well as within the hospitals. This slide demonstrates that 50%, the percent of physicians e-prescribing using electronic health record has increased in all states and the District of Columbia. And as you see, in December of 2008, by far the vast majority of the country was not using electronic prescribing. And as of April 2014, we see up to 81 to 100% of many states are. And just wanted to take a minute to really to talk about the impact of this, the impact of the legibility issues that went along with written prescriptions, and the impact it's had on error, decreasing in error rates, and also the impact it's had on the community. And I did mention that in my role as the Chief Medical Officer of ONC, I took the role in February, and I've been a practicing primary care physician for the past 15 years. And in talking to my patients, this is one of the greatest benefits that they have in saving them time from actually having to take a prescription to the pharmacy. And providers as well throughout the adoption process tell me that it's one of the best parts of the EHR to them, and the convenience of it and the safety and the quality that it provides. Just wanted you to note that healthit.gov, we have a dashboard that you can go to get the most recent statistics on the current state of health IT adoption in the nation. And wanted to really just set that background in terms of what work has already been done. We know that there's been tremendous success in the adoption of health IT throughout the nation, but what's next? What are the next steps that we need to take in order to make sure that we're leveraging this information and technology to truly improve health and care throughout the nation? We'll talk about interoperability and the importance of interoperability, not just between electronic health records, but also throughout the community, and facilitating the connection of the status of health from the community to someone's centralized electronic or personal health record. Innovations in care delivery are essential as we move forward, and we'll give a few concrete examples of innovative models of care delivery transformation. And I want to really underscore the importance of optimization at this point. Many of the electronic health record system implementations that went on throughout the nation did not involve frontline providers, did not involve the input of those that are using the system to really take advantage of the technology and really leverage it to its maximal capacity and potential. That at this point, many providers are working with or dealing with systems that need to be optimized, and there needs to be a focus on how do we improve them? What are ways that we can leverage the technology? And I'll give an example. As Stefan mentioned, I was a Chief Medical Informatics Officer at the Cook County Health and Hospital System for the past 5 years in Chicago. And one thing that was very important to me was to make sure that I was a practicing and active physician, in addition to being our ambulatory CMO. Or CMIO. And I was asked assigned with the task of rolling out our integrated ambulatory electronic health record system. And the first thing I did was talk to the providers that would be using it to talk about what were the things that they would like to see in it. And I had a lot of doctors that were not happy that I was even having the conversation with them. They weren't happy about this transition. And one of the things I heard loud and clear from our primary care docs was we need this to improve our efficiency. So I designed a progress note that once the doctor opened the note, it would automatically populate the patient's preventive health expectations, the date and result of their last mammogram, pap smear, colonoscopy, A1C, lipid panel. The mere opening of the note would bring in the last result in values of those for that patient, with saving the provider's time in navigating through the chart and trying to find and document these values. And so the strongest opponents of us moving forward with the electronic system were thanking me about how it could save them time and making sure that we're looking at the efficiencies of the system. The United States Department of Health and Human Services, we are working on achieving an interoperable learning health system. That health system designed to provide better care, smarter spending, and healthier communities. In order for us to achieve this, there are three key areas of focus that I wanted to talk about today. Number one, improving the way that providers are paid. Number two, improving and innovating in care delivery models. And number 3, broadly sharing information with providers and consumers to support informed decisions. And I want to start by talking about number 2, delivery system reform from the perspective of innovative care delivery models, specifically looking at social determinants of health and how we can impact the community. What are some of the barriers that we need to talk about to think about critical pathways forward in improving delivery system reform? Number 1, the fragmentation of healthcare and social services. I saw it working as a provider every day for patients that would go to see specialists that were outside of our system. The difficulty in getting information back or information to those specialists and making sure that the referral loop, feedback loop was closed and ensuring that that information was available for me to make the best decisions that I could make for my patients. Addressing the social determinants of health, and we'll talk more about that today. Both Steve and I will talk about the importance, not just from the perspective of our own individual beliefs, but what the Office of the National Coordinator, as well as Department of Health and Human Services, is doing to incorporate social determinants into our policy. Community setting challenges, and as Dr. Hasbrook mentioned, context matters. It's important that we look at and realize all of the factors that people are going through in their communities, and it's critical to have customized, tailored solutions for those communities, and the importance of the community needs assessment and knowing what individual communities need and creating innovative solutions to target and impact the health of the community outside the walls of the health center to achieve improved population health. And improvement in payment models, as mentioned earlier as well. It's critical that we design policies and incentive programs that support these innovative models in care delivery, and we'll talk a little bit more about those. So I wanted to talk a little bit about what I've done in the past in terms of population health. I was a co-medical director of a men's clinic on the south side of Chicago called Project Brotherhood. And it's exactly what we're talking about. Meeting the community where they are, knowing that the majority of the time the individual spends is not within the walls of a healthcare center. So the first thing that we did was went out in the community and asked men, why aren't you coming into the health center? What are the things that you would want to see in a health center that would bring you in and make you want to come back? So we had 11 focus groups, and this was in 1998. These focus groups were held with a diverse group of men from the community, and a multidisciplinary care team concept was designed. The fundamental assumptions, World Health Organization definition of health, that health is a state of complete physical, mental, and social well-being, not merely the absence of disease. And we really had to retrain our providers and retrain the clinic to really understand that someone could not be on a medicine, not have a diagnosis on their problem list, and not be healthy. Really looking at the context of where people are coming from and the types of things that they're interacting with in their day-to-day lives are just as essential as the prescription and adherence to a medication regimen or treatment profile. What were the goals? One of the first thing the men said was that they felt that the health center was designed for women and that they didn't feel welcomed when they were coming into the health center, that it was assumed that they were there for STD treatment or some other reason that wasn't designed for them. So we really spent time in redesigning the health center to make it more male-friendly and to ensure that men were respected throughout the clinic. We had abandoned the traditional medical model and created an interdisciplinary team where it was not just doctors, but the doctors worked side by side with social workers. And this is where the social determinants of health come into play and how we completely changed our approach to treating the men of the community and incorporating the social determinants of health. And this slide just demonstrates the traditional medical model there with disease and the healthcare system, and that the cyclical nature that we get caught up in and not understanding the other critical components of the social determinants, including social environment, physical environment, prosperity, general well-being. And as a result, we created a system where there were social workers not only working side by side with doctors that could immediately refer their patients to address social service needs, but a master level social worker would also run a social support group where they would talk about a wide variety of things in the community impacting health. And one of the most important factors and components of the program that we integrated was a barber. So we have a barber cutting hair within the health center for free. So men knew with grant funding support, we had a barber coming into the clinic once a week during Project Brotherhood hours. It was in the evening on Thursdays, where men knew that they could get a haircut and food and a safe place to talk and hang out. And the relationship that many of the men built with that barber, they would confide in the barber. The barber was also a trained health educator. And the barber became the central point of contact to refer the men to the areas that they needed, or the person that could assist them with what they needed in the clinic. It was an integral and very successful model where the barber working side by side with social workers and providers, and everyone was considered equal. One of the other important aspects of the hierarchy of the physician is the only one that can help someone with their health was thrown out the door. And everyone was considered equal on the care team. And it was an important change in the culture of the health center to really make a difference and impact on the men. There was a full range of medical services available, real-time appointments. In addition to walk-in services, there's a walk-in provider available at all times for men. It was a holistic approach to health and well-being, and it was, as I mentioned, in the evenings on Thursdays. I just wanted to mention briefly a grant that we had with the American Cancer Society, where we wanted to start healthcare where the men were in the community. So what we did was we trained barbers and working with the American Cancer Society on a colorectal prevention grant, and started the process of colorectal cancer screening in the barbershops. And I didn't include in this presentation the curriculum that we developed, but at the time we were using fecal occult blood testing cards, and the barbers would give them to their clients, talk to them about colorectal cancer, and encourage them to bring in the stool cards to get a primary care doctor at our clinic. And if they already had a primary care doctor, we would communicate with their primary care those results. And we'll talk a little bit about the standards and the technology infrastructure that's needed to support these innovative models as soon as I finish, and I know Steve is anxiously waiting to talk, but we'll get to the technology aspect of this as well. But I just wanted to mention the innovation of care that's necessary as we move forward and thinking about healthcare where people are, and not necessarily from within the context of an encounter. And how do we think about the infrastructure necessary and the standards that go along with it, so this information can flow and that we can unlock the data that is contained within the electronic health record systems and make sure it's available where and when it's needed most. Just to give a brief context, as we mentioned, of the social determinants of health, and due to time, I'll quickly go through a few of these slides. And just mention that standardized social and behavioral data incorporated into the electronic health record provides important information about factors influencing health and the effectiveness of treatment. HHS and others convened IOM committee to identify domains and measures that capture social and behavioral determinants of health, to identify obstacles for integrating this type of information into EHRs. The committee was charged to identify domains for consideration by ONC and CMS for stage 3 meaningful use, determines criteria for selection, identify domains and measures for inclusion in all EHRs, and incorporating what are the implications, and identify key issues. So just wanted to show you here, as a result, what were the domains and the determinants of health that came up. And the 4 commonly measured domains within the social determinants of substance and alcohol abuse, race and ethnicity, address, tobacco use. I won't go through this entire table, but I just want to emphasize the importance of what are the important determinants of an individual community, and how do we incorporate those determinants within the electronic health record and create a workflow to address them. So where this is happening, I want to give this an example from the Massachusetts Department of Public Health. As a part of their State Innovation Model Testing Award, they created and implemented an open source bi-directional referral system to formalize community clinical linkages. So what they did, there were 5 clinical organizations sending referrals directly from their EHR and receiving feedback directly from these community-based organizations. There are 9 organizations partnered with the clinics, and there were 8 referral types, and just a few are diabetes education, Meals on Wheels, Matter of Balance. And since 2014, they've had more than 350 referrals going out into the community with information being fed back into the primary care's electronic health record system. In summary, and the direction that we're really encouraging that the nation moves towards is really meeting people and communities where they are, and that every community is different. What worked in Chicago, it will not necessarily work in California. But it's important that we have these needs assessments and understand what are the innovative models within a particular community that will work in order to address the needs and the determinants of those specific populations. I want to reinforce the importance of patient engagement, shared decision-making, encouraging the release and the use of data to improve health amongst the population that we serve, and the importance of a person-centered, coordinated care, and making sure that we move away from the transactional nature of an encounter and look at more longitudinal shared care planning. And how can we incorporate and create a care plan that tracks what are the goals of the patient from their perspective, as well as from their disease and diagnosis perspective. It's essential that we create these documents now that we have the technology and share them throughout the care continuum. And as I mentioned, the technology and data infrastructure that's needed to create these linkages is the step where we are now. What are the standards for the social determinants that we can all agree upon so that our systems can interoperate, so that this information can be exchanged from one care setting to another? In our 2015 edition certification criteria that Steve will talk a little bit about, it has been proposed that we have standards around the social determinants, and we've received feedback that the time window for feedback has closed, but we're at the point where we're discussing that feedback and talking about how do we incorporate this into health IT modules, moving away from the data being within an electronic health record, but knowing electronic health records as well as the expanding universe of health IT needs to be able to capture this information and transmit it electronically. Leveraging health IT to address the social determinants of health and improve efficiency. A very critical point I want to come back to is making sure that it's practical and useful at the point of care, on both ends, whether it's from the health center or a healthcare provider in the community. The systems have to be usable. It has to be efficient. They have to be efficient, and we have to keep this in mind as we move forward with incorporating the determinants into clinical and community health workflows, that usability, efficiency is kept in mind. And all of this information and data that we're creating, we need this health information to be unlocked and for it to be portable, that it can move, that it can flow within the community, that we're moving beyond care to improving health, that we're advancing health IT beyond electronic health records, and that we're using policy and incentive levers beyond meaningful use to really inform, pay, and guide these delivery system and practice transformation models. And one of the cornerstones of this is interoperability. And Steve will talk a little bit about the roadmap and what we're doing to promote public-private partnerships to move the nation towards interoperable state. And I'll pass it over to my colleague.
Note to self, Tom is a tough act to follow. Go first next time. I'd also note that I'd probably get kicked off of mailing lists if I did not acknowledge that I did my graduate work at Hopkins, both at the engineering school and the School of Public Health. So it's great to be back here. So Steve Posnack, and then we're also after lunch as well. So in a non-stereotypical fashion, I'm going to do acronym trivia. And especially as a federal government employee, that's always one of the things that we love the most. So how many of you are familiar with SOLO-MO? All right, one in the back. All right, good. Social, local, mobile. So it's one of my favorite acronyms that I've been exposed to more recently. And so a little bit, and especially what Tom emphasizes and what we heard this morning, a lot of our work is about convergence now. And a lot of the disciplines that we had previously been working on in silos, the data is fitting together now in ways in which we never imagined. So the work that we have now going forward, especially in this decade, is figuring out how to get structured data out to the democracy and how we can enable people to use that data to innovate and to do a variety of different issues and act on a variety of different issues that we couldn't have imagined before. So a lot of what we're focused on at ONC as well has been working to develop a 10-year roadmap for interoperability with 3, 6, 10-year milestones. And for those that are worried, I will get us back on track because I don't have any slides, as I'm sure you could tell already. So often we find ourselves kind of asking questions like how and why, and we've got all this data, now what? And so I think we're in a lot of positions now where we're trying to figure out now what do we do with all this data. Tom, I would have never thought to have a barber in a men's clinic. But that's where we're starting to experiment with novel and innovative ways to engage with the communities to deal with different social determinants. And there's an acknowledgement in the interoperability roadmap that as was mentioned earlier, a lot of the factors that relate to health occur outside the traditional kind of medical care setting when you're there for 15 minutes. You could calculate all the remaining minutes of your life that you're not there in the healthcare system. And that, there are a lot of factors in terms of both the accessibility to technology as well as to caregivers and other personnel that make a difference in people's health. And then the one other component that Tom mentioned as well, from a policy perspective, so this is where I'll ask for another hand-raising participation. You didn't know you were going to have afternoon calisthenics, right? So we released a proposed rule with our colleagues at CMS. Ours focuses on the certification process for health information technology. How many of you commented on that rule? All right, one, good. All right, awesome. Public participation in your rulemaking process is very important. We do read all your comments. So for something like this, if it's important to you, it's important as well to us to go through those comments in detail to make sure that our policies are accurately reflecting. So if there's one thing I could do is encourage you next time to comment on rules, as much of a challenge as it may be to set aside some time in your busy lives and schedules. It's really an important part of the kind of public policy process. In that, we propose a certification criterion for social, psychological, behavioral data related to financial resource strain. A lot of the bullets that Tom had up there, education, stress, depression, physical activity, and so on, And that was our first attempt to deal with this in terms of its convergence with electronic health record technology. You could envision situations in the future where a healthcare provider may get some type of clinical decision support based on some of this data as well. And so how we move this data and how it interacts with the human services side is very important for us as we look forward toward that 6 and 10 year milestone parts that we included in the interoperability roadmap. So I think we're at a place right now where we're trying to figure out what data is going to make a difference, what data is going to be the most impactful. And the other challenge that we have is how do we inform without overwhelming? And that's a big challenge that we have both in the clinical context as well as when we try to factor in a whole lot of data that's coming in from outside sources or from other dimensions as well. And so how do we give people a real crisp picture of what's going on with someone without just flooding them, with data, which is kind of at the point where we're swimming in a sea of data, and we need, a few good ships to get us to the right shores. So I'll leave us some time for questions, and thank you very much.
Thank you both so much. So with that, we have a few mic runners that are going to be grabbing some mics. They're spread out throughout the crowd. I think we have a question in the far back corner.
Talked about prescription drugs and the capacity to move those prescriptions out in a more uniform way and more efficiently. It's an interesting area because there's a convergence of medical care, the prescription itself, behavioral health needs, and criminal justice problems. How do you design that system so that it's not just moving prescriptions out faster, but taking the need for treatment for some of the users and the criminal justice element into account at a time of an opioid epidemic?
Sure. So that's a really great question and an example of where there's really a full loop of our work from a health IT perspective. You probably wouldn't have pegged that our office is involved in prescription drug monitoring programs, but that's one of the areas that we have some standards work in as well in terms of how this works really quickly, right? The provider prescribes, it goes to the pharmacy. The pharmacy in many states, if not most, I think at this point, reports controlled substance prescriptions to some kind of registry at the state level. And what we're finding is, that it goes from point A to point B, from point B to C, but it's not going from C to A again. And that's a lot of the areas where we're working in standards now to optimize the provider's experience and to get knowledge at the point of care before they prescribe to someone that may have an opioid abuse problem or issues where they need counseling and other environmental factors that may be able to affect those things. So that's one of the areas where we're looking. It's a secretarial priority that we're involved in as well, and I'll turn it over to Tom.
I'll just reiterate what Steve said. It's a priority for our agency. It's a priority for HHS that opioid abuse is. We talk about models to address this weekly, and it's something that we take seriously, and we're working on ways to solve the problem and really work towards a better system.
Okay. Right over here.
So I'm.
Please stand and say your name.
Okay. So I'm Norma Padron. I'm a health economist at the New York Academy of Medicine. I'm in a project working with the cities of Los Angeles and Philadelphia, trying to assess sort of which data they have, and it's very similar work to the one you're describing. One of the challenges that I've just sort of through my work found is that so cities make decisions and procurement decisions. Agencies within cities make procurement decisions and contract with private partners who offer them technology solutions, and oftentimes these technology solutions do not speak to each other. So when we think about interoperability, it's just inherently, it's a challenge because it's like this very expensive technology solutions were already bought, and they don't speak to each other. But the data is theirs, as you were saying, right? And the willingness is there from the agencies to coordinate and cooperate, but then sort of, and I can see as an economist, like I said, I can see perfectly well the incentives on the private sector to do this, but I feel, are there any, regulations? This is sort of like looking like a health records story where Epic and, not to mention names, but they don't speak to each other, right? And we know that. I have an appointment at Sinai as well. I teach there, right? And I worked on teams where, within the hospital we have records, they don't speak to each other. So is there like a goal to have regulations in place? I think like maybe this is something where the standard has to be established because the private sector in itself might not do it.
I just joked with Steve and I said he planted you in the audience.
He said it was a softball. It may even be underhand pitch too, right? So, one of the things that Tom emphasized that he went over quickly is the department's efforts related to delivery system reform. And as we start to see payment models change, that's really getting to the provider behavior. And I think we're starting to see health IT developers react to that much faster than just a pure regulatory hammer saying thou shalt do these things. To the degree that providers need to reach specific outcomes where the financial incentives are aligned to support those outcomes, as well as a recognition that having the information available is going to allow them to treat patients way better than when the systems didn't communicate. At the higher level with ACOs that were mentioned before, if you don't know where your patient is and where they're going and what treatment they're getting, then you're losing out on that type of models relationship. So there's I think a broader demand that we haven't seen 5 years ago, 6 years ago, because of the delivery system reform changes that are coming in place, the models that are now showing promise, and I think an overall willingness that I would say, since I was mentioned 10 years before, we have, it's refreshing, I guess, for lack of a better word, and we're starting to see a lot of the prior interests evolve. But there is a large legacy base in terms of investments. I don't want to be tweeted or quoted as calling any of the current health IT systems legacy. But there are a lot of investments made, and people need to iteratively migrate from one way of doing business to another using the systems and the data that they've acquired, which is rich in some cases.
I think this is a good point to talk about the Interoperability Standards Advisory. Can you just talk a little bit about the intent and
Sure. So we also, in addition to the interoperability roadmap, which we had a comment period for as well, published a guidance document which lists specific purposes for which people are looking to achieve interoperability. That's another stump speech and presentation for another day for me. But suffice it to say, not all standards support, there isn't one standard that supports all your use cases, right? So e-prescribing has a different standard than lab result reporting, and you need to have a level of specificity that's at a sufficient level of granularity to really get the job done. So we put together what we hope is available. It's publicly available, but that people that procure systems will be able to look to as a real actionable element to say, does the system I'm buying or want to buy include these standards?
So I think we only have time for one more question, which I know is unfortunate because I see like 5 hands popping up right now. But why don't we go to this gentleman right here?
Our original plan was to filibuster, the whole presentation.
Yes,
so.
yes. No questions.
Scott Beck-Levin from the Community Information Exchange in San Diego. We're doing a lot of interoperability work between social service agencies, and a lot of the work that ONC does, of course, is around meaningful use around electronic health records. So as you look at social determinants and the standards, are you looking beyond the electronic health record to setting social service standards, NEAM and AIRS and other types of solutions?
The answer to that is yes. And I think the connection between the two is really where we're starting to focus our attention and to figure out where and at what level certain standards would apply. NEAM has certainly been mentioned, and that has its strengths at certain levels. In other cases, there's no need to necessarily reinvent the wheel from a healthcare standards perspective too. But finding out where there's complementary aspects and finding out where there are differences, and where organizations such as yours can help play that intermediary role to connect the two is going to be important.
So since you actually gave your secret up, now we're actually going to afford time for 2 more questions. So in the back here, Mr. Gold, and then in the front here, the woman in the peach shawl will be the last 2 questions for now, at least.
My question is to Dr. Mason, and it's, in your expert opinion, do you consider the social determinant information as part of the patient's health treatment?
I'm so glad you asked that question. I forgot to mention that in my talk, and I wanted to give concrete examples. Yeah, I wanted to give some concrete examples of how we could integrate the social determinants into a clinical workflow where they could have an impactful or be a part of an impactful process. One of the things that's ongoing in some health systems that I think needs to be replicated and scaled is the capture of social determinants electronically and creating a task list where those specific determinants could be routed electronically to someone on the care team. It doesn't necessarily have to be the physician, but I think the physician or provider definitely needs to know. But creating a workflow, and we shouldn't just have data and not have it be actionable. That if someone gives us some information about a critical aspect of their life that's going on from a social perspective, what are we going to do with that information? How do we integrate that into an electronic workflow where certain tasks could be routed to a social worker or a mental health professional that once we have these standards in place where we can capture the data electronically, we can design innovative workflows where a specific determinant can have a specific task that is routed somewhere. And it doesn't necessarily have to be routed within the health center. There's a way that we could create linkages with community partners to have specific issues addressed through a referral process that all starts with being able to capture, process the data, and in knowing that this is an important part of this person's health, just as important as doing a medication reconciliation or making sure that we're reconciling the problem list. How are we capturing this data and using it to be an impactful part of someone's life?
And our last question.
Thank you. Hi, my name is Andrea Reed. I'm from Department of Homeless Services in New York City. So I was wondering if you're doing any work around young children and psychotropic medication and how the social determinants are influencing, their response to the medicine, and what are you working on around rules and standards?
To be honest, that's not an area that I think that we've touched on as a specific topic.
But that's the other thing I wanted to mention is we want to bring back the information and feedback that you're giving us today back to our leadership, and a very valuable point, and I appreciate you bringing that up, and we'll definitely bring that back to the team.